Hi, everyone. Welcome. Happy Wednesday. As you're logging on, go ahead and put your name in the chat. Tell us where you're joining us from. And any particular questions you have that brought you to this session today. Youth and Matt. Whew. It's a big topic. So go ahead and share your name, where you're from, and any questions that you have. We would love to hear them. My name is Elizabeth. I'm the Clinical Program Director of California Bridge, and really happy to see you all today. Can't believe we've been doing these Changemaker sessions for a year, Reb. I can't believe we're back a year later. Reb did our very first Changemaker session last November. So hard to believe it's been a year. It feels like not a year has gone by since you and Alicia and I did that first session. So. Hi, Dr. Nestor, welcome. We're so excited about all the work being done at North Bay. So good to have you here today. Yeah, go ahead and put your name in the chat. Tell us where you're from. Hi, Troy, good to see you. Hi, Tina. Also super excited about all the work going on at Clear Lake. We just are onboarding your new champion to our alcohol use disorder work group. Really exciting. Yeah, Christine is awesome. We know. Yes, she's one of those sons we want to clone. She's doing so much work on behalf of your hospital. Great. Welcome from Southern California, Pomona Valley and MLK. Yeah, it's really exciting, Tina. I'm really excited we were able to get Dr. Roden into that work group. All right, friends, we're going to get started in about a minute. I'd like to introduce Dr. Reb Close and Dr. Sharam Lotfipour, who are joining us today and are going to have a lot to say about youth and MAT. So again, putting in the chat anything you want to tell us, your name, where you're from, and any particular topics you are hoping to learn about today. We know this is a big topic. This is probably the topic that we got questions about in our first 18 months of running this organization that I did not feel like we had good answers to. And that realization is why we have done so much work and why we are here today. So I think we can go ahead and get started since we do have a lot of material to get through. So welcome, Be the Changemaker, Youth and Matt. Let me go ahead and advance my slides here. So California Bridge, as a reminder, is a program of the Public Health Institute. And Caroline, anything you want to say about Zoom etiquette? Otherwise, please use the chat and make sure that you're messaging everyone, unless you do need to send me or someone on the bridge side a private message. You can just go ahead and make sure you're sending a message to everyone. We will see it. We welcome questions, comments as we go. Caroline, anything you want to emphasize?
Nothing else to add. Yeah, just a reminder, whenever you're sending chat questions, make sure you address to everybody so everybody can see. And if you have any tech issues, feel free to message me directly at CA Bridge, and I'll be here to help.
And we do have closed captioning available for this for any accessibility needs that solves. So who are we at California Bridge? Nice to see some familiar names. If you are not familiar with us, our goal is to provide 24/7 access to high quality treatment of substance use disorder in all California hospitals by 2025. This slide is actually outdated, which I should have caught. We are now at about 155 hospitals implementing the CA Bridge model, and we do not have any disclosures. So this is what we're up to. We began our programming in October of 2018. So as you can see on this graph, we started just over 2 years ago with 0 hospitals that were being formally supported to offer MAT in the ED. We're now at about 150, and our goal is that by the end of 2023, we will be in every hospital in the state. So we are well on our way. If you are at a hospital that is not currently receiving funding to have a substance use navigator in your ED, please reach out to me after this training and I will give you information about what to look for so that you can get that funding. If you are at a hospital that is receiving funding, you will be eligible for more funding early in 2022. And as soon as we have the details for that, we will shout them from every rooftop that we possibly can climb to. So anyone wondering about the future of that funding, please know we're working very, very, very hard on our end to get those details to you. And as soon as we have them, it will be impossible for you to miss them. I'm happy to say if you were able to join a training like this, you will receive that information. So really excited to get to this goal of mat availability in every single hospital. All right, Reb, take it away.
All right, so thank you everybody for being here. I am really excited to get to bring this topic with Sharon and with Elizabeth to you, and then really excited to engage as we kind of learn from each other. I will say though that this presentation will discuss drugs, paraphernalia, and overdose that can be emotionally difficult or triggering. So I would ask that you take care of yourself, and this can be a hard topic, especially as we talk about it as it relates to our youth. And so I just wanted to put that out there, is to be aware that this is tough, and we know that. Next slide, please. Thank you. And so that is my next slide, is thank you. So first, thank you for being here. Thank you for taking time out of everybody's busy Zoom days to be here for this opportunity for us to work together on this. And I want to thank you as well for bringing kindness to the care of our patients. This is a challenging topic. It's a challenging group in many ways. And I appreciate that you are here to rise to that challenge. And I would ask that you remember that these patients have the rest of their lives ahead of them if we can help them achieve recovery. And I keep that as part of my true north, is what keeps me moving forward, as I realize that if we impact and have a positive impact on our youth, they have the whole rest of their lives. And when I was in my training, I learned that one pill can kill. And that was a specific group of medications that were thought to be lethal, or that are lethal to toddlers by their dosing. And unfortunately, that now applies to anyone, given our current street supply. And so I just wanted to put that as something in our awareness of what we're going to talk about today. And the next, thank you. Our objectives. First is to understand the current landscape of substance use disorder in our youth and some of the current trends. We need to differentiate between the options of treatment for substance use disorder and how they differ for youth versus adults. And specifically, we are talking about MAT, as that was mentioned earlier, and then review some of our youth-specific outreach and engagement strategies and how we really need to tailor them for the situation. There's a different way you approach a youth who has episodic or I used to call them my experimenters compared to those that are dependent or addicted. And so you need to take that into consideration when applying some of the topics we're going to discuss today. So with that,
so we want to do a quick poll, and we have truly a lot of people on this chat. So really excited to see what you have to say. So we're going to launch a poll on our end. We want to know what you know about this topic. So like Reb said, this is a hard and big topic. You should be able to do this from a PC or a phone, whatever device you're on. Is your hospital providing addiction treatment for adolescents and young adults? And how would you characterize your resources? So, and resources can be, think about your community. When you do have youth who present with substance use disorder, how well equipped do you feel like you can treat them? So we'll wait about a minute and a half or so. No judgment if your if your answers are no and there are no resources. That really helps us understand who we're talking to, and these answers will really help Reb and Sharam make the guidance that we're about to share as close as possible to what you need. So I think we're good, and it looks like, okay, so it looks like we're about 50-50. About 50% of folks here are providing addiction treatment and 50% are not. And shocking, no one presenting today. Sounds like most folks feel like they're pretty under-resourced. So thank you so much for your candor on that question. And we're going to go ahead and dive in. So Sharam, what do we know about youth and addiction?
So hi, thank you very much. This is Sharam Latvapour. Although I live in Southern California, my heart is always in Northern California for those from that area. I'm a professor of emergency medicine at UC Irvine and fortunate to be training young folks as a residency director for emergency medicine at Eisenhower. So there is, a lot going on when it comes to suicide cases that are important to realize. So overall, when you look at the numbers nationally, they're not concerning, but one of the things that is very concerning is what we're trying to point out here. So this is the National Poison Data System from the American Association of Poison Control Centers. So the ISS cases, or the intentionally suspected suicide cases, looking at them by gender, is pretty significant. As you can see, the number of female cases is significantly going up most recently. As you can see, it was pretty flat, 43 to 46,000 cases in 1 year, and it has almost doubled. Surprisingly, that is not present. It's more present for the female cases, which kind of shows some of the disparity that's happening. And the teenagers, they consider teenagers for this as 13 to 19 years old. And then for the children cases, they consider that 6 to 12 years old. As you can see, there is a significant increase, even more than that. So, 1,700 to 1,400 was kind of the baseline, and that has gone up multiple times. So the scope of the problem is pretty significant. So according to the CDC, which kind of helps us provide some of these data, 2009 to 2019, so the 10 years based on a youth survey that they've done, 14.8% of high school students have used cocaine, inhalants, heroin, meth, hallucinogens, or ecstasy, or easier to remember, 1 in 7 cases. 1.6% of high school students injected illegal drugs. And these are, as you know, surveys traditionally always feel like they underreport what's going on. So if people are reporting this, potentially the scope is higher. 14.3% have ever misused prescription opioids. Again, a very large number. So 1 in 7 students, again, misusing prescription opioids. 1 in 14 students reporting misusing them during the past 30 days before. So just to put that into perspective, in California, where we're very passionate about, and probably we might have people from outside California joining it, that's over 300,000 cases in the 12 to 17-year-olds. Among 12th graders, 1 in 5 reported using prescription medicine without a prescription. So, just kind of getting a little back to basic science as we were back in school. And I know it's important to always consider, why is that? Why is that very important? So, adolescents, their brain is still developing, and one of the neurotransmitters felt to have an important area of influence for this is dopamine. So dopamine is the neurotransmitter of reward and anticipation of reward. They say kind of goes up if you have a really great day. Just to give you a number to remember, it can give you like 100 nanograms per deciliter going on. Substance use gives you 3 to 15 times that. And they also feel that with tobacco use, at least from the research that has been done, that tobacco use potentiates that. As you know, the tobacco use has significantly increased in teenagers and younger than that, and that potentially potentiates the effect of the dopamine increase with substance abuse. So they think that there's activities, certain activities, obviously a great day, your first kiss, all of these increase your dopamine response. And we know that, that younger adults have underdeveloped prefrontal cortices, so this creates a little bit of a difficulty prohibiting themselves from doing things in the judgment, so weighing the risks and benefits of their decision. So as we were growing up and as younger, our kids are growing up, risk taking and exploring is normal, and we need them to do that, but that also is heavily affected by substance use. And although, not specifically targeted by what we're doing, but, tobacco use potentiates that. Just some terminology to realize. So patterns of use, most of the folks are abstinent, not using. They might experiment. They could be a recreational or social user, so only in certain situation. They can then advance to becoming a regular user, repeating sustained patterns of use. They could be abusing, which is continued use despite the negative consequences, or they could be dependent, which is continued use, because if they don't, they're going to be withdrawing. And addiction obviously also comes with a significant psychological dependence. And so in adolescence, any of these uses, obviously above abstinence, is worrisome. And it is concerning as a disorder for us, and it's something that we'd like to have an effect on.
So knowing all of this, seeing these extraordinarily alarming numbers about drug use in teenagers specifically, what did we decide to do? So I will share in my role as clinical program director, this was the topic I got the most questions about that I did not feel like we had adequate resources to answer in CA Bridge's first 18 months of our pilot that we ran from 2019 to 2020. So based on that knowledge that we just kept getting questions, well, what about teenagers? What about youth? What about somebody who's under 18 who might require consent? We had the opportunity to apply for some funding through YOR California. They envision a California in which youth who are misusing opioids and stimulants are identified, engaged, and have access to an array of treatment. So we were really, really honored to receive this funding from YOR California last spring, and Reb and Sharam and I, along with a few other representatives from California Bridge model hospitals, are working on a pilot to increase access to treatment for youth and to see what we learn that will hopefully be applicable statewide and maybe even wider. So the 4 hospitals in our pilot are Children's Hospital Orange County, Community Hospitals in Monterey Peninsula, which is Reb's site, Eisenhower Health, which is where Sharam leads, and then UC Davis. And something I'll point out about Children's Hospital Orange County is they're actually to date the only hospital who has put up their hand to have funding for a substance use navigator in their hospital. And we're working with the Children's Hospital Association of California to make sure that we are able to place these critical resources in every children's hospital next year. So every hospital is a stakeholder in this. Every type of hospital is seeing youth with substance use disorder and can benefit from the knowledge we're about to share. So this is what we're working on in the pilot, very youth-specific engagement screening, assessment, referral resources, youth-specific navigation and case management, understanding of the considerations of prescribing MAT to youth, which Reb is about to discuss, and very critically, having materials available for family and caregivers. Very often, folks in this age group who are presenting with substance use disorders are still engaged in family structures that can serve as a source of support for them if they're properly supported themselves. So the numbers, this is a glance at the first 7 months of our pilot. The 4 hospitals have identified a little bit over 200 youth who are eligible to receive these services. And we've started about 40 youth on buprenorphine. That number might be a little bit higher. I'm missing one hospital's data for last month. They know who they are. And we're really happy about this. However, I'll note that number 213 is a whole heck of a lot lower than that 300,000 number that Sharam shared. So we will continue to increase the ability of hospitals to treat these patients as they present. So Reb, how are we going to do that?
Yeah, so, and just because I didn't do a formal intro, just so you know why I'm talking to you about this. So I'm an emergency physician, but I'm sitting for my addiction boards next year, and I work at community hospital. And so that's the background of what I'm going to be describing to you about what we can do. So as part of our youth work, there's so much outreach and engagement, and we need to educate the youth, their parents, their coaches, their student support staff at schools. I mean, we need to inform and educate our communities. Obviously, this is a team sport and it's all hands on deck. And so utilizing your resources to educate and inform your community members is key. Destigmatize this disease and destigmatize your language, the way you approach this. And we're going to talk about this as we move on. And reaching out into your community, we've really started engaging with our schools. The students that are part of the work that I'm doing have talked about, let's go to the skate parks, let's go where the kids are. And I keep that there as the meet them where they are. And that goes for outreach and education to our youth. And then prevention, for me, as much as I desperately want to get our kids into treatment, if we can prevent any family, any child from unfortunately ending on this pathway that we are on right now, I'm going to call that a win. So we're going to talk about treatment. We're going to talk about some of these other things, but I wanted to highlight them as we first started.
Yeah, I would love anyone who has the chat open, if you want to do a little off training brainstorming, just where you and your community would go to look to do outreach for these youth who might be struggling, as Reb continues to talk.
Yeah. So when we talk about treatment, and I just throw this out there because in 1995, France decided you do not need an X waiver, just physicians and physician assistants and our team, please prescribe this life-saving medication. And with that, 10 times the patients that had previously needed treatment for opiate use disorder were actually able to get it without this requirement of an X waiver. And their overdose deaths within 4 years declined by 79%. So that is just the first of many slides that I'm going to use to talk about how this treatment actually saves lives. So number needed to treat is something that our clinicians are pretty familiar with. And basically what that is how many patients you need to treat to get an outcome that you have of interest. And so for our medical training, proton pump inhibitors is a class of medications that we give routinely to patients with an upper intestinal or an upper GI tract bleed prior to the procedure of endoscopy. We are trained to do that. This is part of what we do. Well, the number needed to treat with that intervention to save a life is infinity. No life saved, none whatsoever. So we give this medication, it's part of our training, it's routine part of our care, no mortality benefit, nothing. So then if you go, okay, fine. What about aspirin for primary prevention of a heart attack? Okay, I have to treat 2,000 patients with aspirin to prevent one heart attack death. Okay, aspirin's cheap, I can go for that. 3,000 patients I need to treat with aspirin to prevent one non-fatal stroke. Okay. It's an inexpensive, fairly safe medication. That makes sense why you would do it. Now we start getting into something that has a mortality benefit. So the number needed to treat to give antibiotics for a patient with liver disease who has upper GI tract intestinal bleeding. If you treat 22 patients with antibiotics, you will save a life. That I can wrap my head around. I like that. And if I treat 4 patients, I'm going to prevent an infection and possibly those complications. This is all good. Here's the win. To treat opiate use disorder with buprenorphine, for every 1.4, so every 2 patients you treat, you've just saved a life. There's nothing else in medicine that has that mortality impact. And so think about it. When you're taking care of these patients, when you're connecting them to care, when you're getting them buprenorphine, you're saving these lives. And so talking about mortality benefit, this is all-cause mortality, no treatment they have over a 6 times higher all-cause mortality, are patients with opiate use disorder. When you get them on medications for assisted treatment, you bring that back to less than twice the general population. It is still a dangerous disease. We all know that. Diabetes is a dangerous disease. That being said, you can impact and you can make this change. And when is that mortality? It's right after an overdose. And granted, this isn't every patient, and this is data showing, however, that the fatalities happen most predominantly in those first 72 hours after a non-fatal overdose. And I will say we had a non-fatal overdose in my emergency department waiting room yesterday. Okay, they got naloxone for the patient. They resuscitated the patient. You know what my doc did? Started the patient on buprenorphine. So he saved a life yesterday. And that's why this is important. So we're going to talk about MAT, but one thing I want to mention is this is only one part of our overall treatment. These patients need that outreach, they need the intervention, and they need to be connected to care. And what we've started asking, and instead of the thought process of what's wrong with this patient, why are they using substances, it's what happened to them. What makes a viable choice for a 15-year-old to be in this circumstance? I would ask that our substance use navigators and all of our teammates consider that, because we need to get to the bottom of that in order to really connect with that patient and help them maintain their treatment and their care.
Thank you, Reb. As we continue to talk through these MAT for Youth basics, I want to let everyone know we got some great ideas for outreach in the chat. And a few of you are sharing that counseling centers and other resources in your area do not talk about MAT for youth. And we will be sharing, everyone who is at this training will be receiving our guidance. We have some youth specific flyers and outreach materials that you can take and bring to those places that are youth facing that should help solve that gap.
All right, so I know many of you are familiar with this, but just so we're all on the same page, opiate use has a pretty natural progression. And so if I'm a 15-year-old, I'm feeling okay, not bad, but I want to feel better, and I take an opiate, for that period of time, I'm gonna feel awesome, much better typically. And then I'm gonna come back down to where I've been, not too bad, not too good, things are okay. And then I'm gonna do it again. And frankly, I may not get that level of euphoria I did the first time. And as I continue my use, as you can see, my euphoria comes down. And ultimately, the only thing that I feel when using the drug is no longer feeling withdrawal. And so if you understand that, it helps you understand why patients seem so uncomfortable and so you very much understand why they use when you understand how miserable they feel as their dopamine comes down and they crash and they go into withdrawal. What the opiate agonist therapies do is they bring that patient back up into a normal zone. And you see there aren't those peaks and valleys anymore. It's more of a steady state. And that helps with preventing their cravings and preventing seeking out substances. So how does MAT work for opiate use disorder? Prevents the withdrawal, as we just showed, and it controls those cravings, and it really helps the patient feel well enough to actually work with you in their treatment plan. And so there are 3 main medications that we use for opiate use disorder. Methadone is a full agonist. It binds the opiate receptor and activates it fully. And we'll talk about that. Now, Trexone is an antagonist, so it binds it but does not activate it. And buprenorphine is a partial agonist antagonist, so it binds and it activates but not fully to the full agonist level. So the next slide has a graphic helping explain this. But this is one of the reasons we use buprenorphine so regularly. Methadone needs to be used through a methadone clinic. And many of us in the ER don't have those immediate connections specifically for our youth. But when it comes to buprenorphine, as you can see, the green represents the full agonist, so it binds the receptors fully and activates them. The buprenorphine, it binds the receptors, but has a ceiling. And that ceiling is for respiratory depression. So even if you take giant doses of buprenorphine, you are not going to have the level of respiratory depression that you would with taking a full agonist. The sedation as well follows that same pattern, but it seems that with using buprenorphine for analgesia, higher doses will help with more analgesia. So that's nice if you're going to use it for pain control. One challenge with buprenorphine is that it does block other opioids. So if I have methadone in my system and all my opiate receptors are attached with methadone right now, if I take buprenorphine, that will move some of that methadone off the receptor and the buprenorphine will bind but not fully activate. So to me, that would feel like withdrawal. And so you need to take that into consideration. And even though buprenorphine has a long half-life, some of our patients actually need it several times a day. And so for me, I really work with the patient on what they need when they're starting to feel withdrawal and cravings. It's time to redose. And a really important thing, as I mentioned earlier, with buprenorphine being widely available, any prescriber can administer buprenorphine in a hospital or in an ER for 3 days. No waiver, no X, no nothing. In order to write it though, even though the X waiver requirements change dramatically, you don't have to go through all the training, but you do have to do an online click form. In order to do that, you do need the X waiver. I will give you a treat of one of our teammates literally wheeled a computer through her department to her clinicians and said, hey, I'll do that X waiver thing for you now. So frankly, that can be done. They have so many more X waivers that are prescribers that now have their X waivers. So I'm going to use that my shop, but I wanted to throw that out there as an option. All right, so for me, you've heard me mention the 15-year-olds, and frankly, that's the reality. I never, when I started in medicine, thought that I would have a 15, 16-year-old physically dependent and addicted to fentanyl that I would be taking care of. That I could not have imagined that moment, but we're here. And frankly, we need to normalize the care for these patients like we do for every other chronic disease. So you treat your emergencies, you address any crisis. You also expect that there will be periods of good days and bad days, relapse and recovery. How many asthmatics do you see multiples of times? Because asthma is a chronic disease. And so just realize that's what we're doing here. Now, there are some patients that are going to be more likely to follow up than others. Really? Same thing with my diabetics. So just keep in mind, you've got to normalize this. This is what we do. And these are the patients that we need to take care of, and they're here for our care. We go there. We go. So just kind of keeping in mind, I mentioned asthma, I mentioned diabetes. Treating any disease in adolescence can be challenging, and that's why I said thank you for rising to the challenge. So that's what this is all about: is you do what you do. Same thing you would do for your patients that are suffering from depression or anxiety, any challenging disease in adolescence, and realize that that's what we need to view our substance use treatment for these patients. And even our Surgeon General has been very vocal, and I so much appreciate it, to remind people in a public forum that addiction is not a character flaw, it's not a moral failing, it's a chronic disease that we need to treat with, like every other chronic disease, with skill, compassion, and urgency. So please keep that in mind as we move forward. There's so much support for this care. It matters, and that's what we need to do. So I'm going to turn over to Sharam to talk about the differences in treating youth, where I've just described a lot of things that are similar to what you do in your adult patients.
Thanks, Reb. Before we have Sharam take over, we actually got a clinical question in the chat I want to ask both of you. And while you're answering that, for folks who are on this training, we are about to dive into consent and what the consent considerations are in treating youth. So if you have specific questions about treating youth from a consent perspective, please put them in the chat so we can make sure we either get to them or potentially know that we have to look something up later, because this is pretty sticky. So while you go ahead and put those consent questions in the chat, We got a question from a doc on the training saying, seeing young adults, I occasionally see patients in the first phase, the binge intoxication phase. Some of them judge buprenorphine's success by whether they feel euphoria. So it's hard to know whether they're having the full positive impact we want. Reb, you brushed on that briefly. Do you want to speak to that consideration of they want the euphoria through the buprenorphine?
So buprenorphine does not cause euphoria. Go ahead. I'm sorry, Sharon. Were you going to pipe in?
No. I was just listening.
Oh, yeah, it does not. And in fact, we were talking about it, that if I were to have surgery and were to require an opiate, I would be much more comfortable having buprenorphine because you don't get those highs and lows. So, I mean, that's part of the treatment. That's why we use it, is it blocks the cravings, blocks the withdrawal, but you don't get the high. I don't know if that answers the question adequately. I couldn't read it because I can't find it in all the chat. There's so many.
Yeah, no, I think that's just important, what people are actually seeing from youth on the ground. So we know what people might actually receive back when they're offering these options. All right, so Sharon, tell us about consent.
Oh, perfect. Thank you very much. Thank you, Reb. So, there's obviously many different things about treating youth, and we're going to try to go through some of them. So consent issues. So, a minor, 12 years of age or older can consent to medical care and counseling related to the diagnosis and treatment of drug or alcohol related problem. If you're thinking about doing medication assisted treatment, parental consent is required for a minor's participation. I'm sure you guys have dealt with some of these issues if you've tried to take care of minors. Not often seen, but you might see some emancipated minors. And although, it might be different between different states, at least, an emancipated minor is someone, as it comes with for medication for addiction treatment, you would look to see if they're self-sufficient, usually 15 or older, if they're living apart from the parents, if they're managing their own finances, even if they're not earning their finances. That would be someone that you could consider emancipated minor and might not require parental consent. Other adolescent considerations, they're adolescents, just because they're the same age, there's going to be very big differences, as you are well aware, between individuals of the same age. And it could be due to either the different cognitive development, not just limited to adolescents, but people have different healthcare beliefs. It might be more pronounced than adolescents, as they might have not developed their own, and it might be more the family beliefs, the cultural beliefs as well. They might have very strong feelings about their prior experiences, as they might have not had very many medical experiences. And, it's difficult trying to balance between, having them kind of being involved in the decision-making, providing them appropriate independence, and also having the parents involved. And it becomes very much a little bit of a high wire act, but it's definitely a partnership between all the parties involved. And that's why it can get complicated and challenging. Some of the terms to use are easier to say, and unfortunately we've heard many terms not to use. So the terms to use is try to emphasize saying, a person that uses drugs, a person with a substance use disorder, a person with an alcohol use disorder, a person with an opioid use disorder, a person in recovery, and whether they have negative or positive toxicology test results. And basically the terms we've been using for many, many, many years should not be used: addict, abuser, user, junkie, druggie, alcoholic, drunk, oxy addict, meth head, ex addict, former alcoholic, clean or dirty test results. So as we know, a person is a person first, and the behavior can definitely be changed, modified, and adjusted. So we need to just focus on the person and not on the behavior. And I think that would keep us on the right side of the patient.
So we're going to talk through some interviewing techniques to reach adolescents specifically. Before we do that, we did get a question in the chat about consent. And as a disclaimer, none of us are lawyers. We just know some very helpful lawyers. So we might need to report back. But Reb, the question is, how do you approach consent for youth experiencing homelessness who are not yet legally emancipated? Have you seen this?
I have not had that specific scenario. I'm trying to think. I'd have to kind of reach out to my team and see. But that's a very, very good point.
It's a very good question. And based on some of the names I see on this chat, I know that many of you are working with high populations of folks experiencing homelessness. So we can look into that and maybe even add a line to our consent guide that speaks to that. So thank you for that question. Go for it and tell us about how to reach these youth via interviewing.
So, we would love to hear some of your recommendations that have worked. You guys, we have a wealth of individuals on the call, and we'd love for people to hear from you about what tools have worked for you in the past, trying to talk to interview adolescents. I know it's challenging, so feel free to put your comments in the chat so other people can hear them and can help us. These are not true to just adolescents, they're true for any age, but obviously we want to always encourage questions instead of preaching to them. You know that better than I do. Trying to start with neutral, less charged topics. Be extremely careful of privacy and confidentiality with every patient, but I would say even more with adolescents, as they probably are more cognizant of it because they want to ensure confidentiality and privacy. I think it's easy for us to be in a lecturing or judgmental format and trying to keep reminding ourselves not to be like that. Going along with the privacy confidentiality, don't talk with others. Be aware of our nonverbal cues that we are conveying to the patient. The active listening is definitely something to keep working on always. Try to keep it simple, honest, straightforward, and clear, and restate, paraphrase, make sure you understand what's going on and make sure the patient understands what you're trying to say.
I love this comment we just got in the chat. It's so relatable to me. Ashlyn, who's part of our Sun workforce, says, I have no clue. I don't have kids myself, and I've been out of the loop with youth for years. That's so relatable. So again, we don't assume that anybody working in this addiction treatment field naturally is going to know how to relate to youth and to this age group. So that's why we're talking about this, and that's why we're talking about it as a separate topic. So thank you. Thank you for that candor.
And there was a couple of links that we are also putting in the chat that might be helpful, both for the consent and the adolescent consideration links. One is the California Bridge, one is outside, but just wanted you to have some other resources. And, obviously remembering that medication addiction treatment is only part of the plan. We need really a village, a team sport of people. Social workers are priceless, always helpful, connecting with families, helping us, connecting with the patients, connecting with our clients. The substance use navigators through California Bridge, or if you have one yourself locally, staying on top of it with patients and connecting them to providers, patients and family. Our case managers, child psychiatrists, psychologists, addiction specialists. I know maybe not every place you have all of those resources, but these are all very, very helpful that kind of create the whole world of adolescent addiction treatment. And some places have more resources than others.
Yeah, and someone in the chat is calling out, it's important to be transparent and truthful with working with youth. I think that's true. I've heard from my friends who are high school teachers that kids will just sniff out if you're not being authentic with them from a mile away. Great.
Thank you. I wanted to just mention, I looked through the chat really quickly for Dr. Cundiff. Thank you so much for clarifying some things in there with your experience. Yeah, you're absolutely right. With naive users, there will be obviously a different experience with buprenorphine than our chronic users. So thank you so much for clarifying. I wanted to share this. One of our sites has gone so far as to make an adolescent buprenorphine order set. And again, this goes back to normalizing treatment and care. And I'm not saying this is the order set for any particular other site to use, but just again, how you can really build this into your workflow. I saw some things in the chat about not having enough providers to cover. And yes, a course isn't the answer. We have, in my area, we kind of have a phone a friend tree where we have various members of our community that are available to answer questions and to talk to each other in the middle of the night on shift. I've actually called the California Poison Control line to ask for help. So supporting each other is critical. So thank you so much for bringing that up as well. But I just want to say this is an option, you know, build it into your order set, make it something that's just like every other disease that you treat. And if you're noting this, probably all this stuff that we talk about with the treatment looks awfully familiar. You know, this is stuff you're doing anyway. So you already know this. You already know what you're doing. You know, when you think about the patient that's 80 pounds, you may consider different dosing. You may consider different dosing depending on their use. It shouldn't be that much different when you're talking about someone who's 15 versus someone who's 25. The big issues are what Sharon brought up about, you know, making sure that you've dealt with the consent issues, and then as well, the sensitivities of treating any adolescent. So with that, I think we have our resource page as our next slide.
Yes, so this is our resource page. There's more than 70 resources on it, including our resources specific to treating youth, which we have shared in the chat and we'll send out as well. Would love to hear what questions are coming up for folks. And even if not questions, we would love to hear specifically from you and your hospitals why this is hard. So we do a lot of work in our small pilot work group, just talking about barriers that we've faced in treating youth. So why is this work hard? What specific challenges have you faced treating youth patients compared to others? Curious, you can use the chat and we may ask somebody to unmute, but we'll use the remainder of this time to take questions and see what we can do to help. Low insight. Would love to know more what you mean by insight and low insight into why youth are struggling with this. It'll be available, the recording will be available probably later this week for sure. Yeah, if not tomorrow or Friday. What else are folks seeing when presented with youth with substance use issues?
I would definitely agree with the comment that the low insight, you know, definitely on the, maybe on the patients, maybe on the family, you know, maybe on, potentially, you know, with the healthcare, not the healthcare team, your healthcare team, but maybe the healthcare team that normally works with the patient outside of your visit with the patient. The insight's definitely a challenge because I think we're all surprised by the numbers and the propensity of the problem. So if we're all surprised, then, you know, that's not something we're often thinking about.
Couple good things coming into the chat here. Hey, Reb, here's a good question for you. I've encountered the perception or misperception that there are more serious long-term consequences for buprenorphine use when started in teenagers compared with adulthood. What do you think?
Yeah, I was reading that and I have not heard that. I wonder, I don't know that there's enough long-term data, but if anyone knows differently, I'd love to hear any insight on that because I've not heard that and I don't know if we have the information we need for it yet.
Yeah, I think, you know, from our perspective, it's a misperception But, maybe when more data is available, we'll see if it's real. But right now, we have no reason to feel that it's any different in adolescents than adults.
And then also consider the not treating risk. With what we're seeing, specifically, I saw a question there about where are they getting the drugs. My kids are getting them on the street from a friend. It's almost universally is my friend gave this to me. And our street supply has all kinds of stuff in it, but fentanyl and the synthetic benzos, atizolam being one, are in my street supply, and that's where they're getting it, is friends.
We've heard mostly teens get the drugs from their friends. We also have heard stories of dealers using Instagram stories and other forms of social media that vanish to sell their supply, which is very alarming. So those wonderful friends. Yes, exactly. Well, it seemed like it at the time, right? That's the low insight part.
And to Dr. Cundiff's point, mentioning that counseling, peer support are the stars of the show, medication secondary, that's beautifully articulated, because that's exactly earlier on when it's MAT is part of it, but making sure that you're getting to the underlying problem, trying to address what is making the kid take that pill to feel better. I think very well articulated. Thank you so much.
Yeah, and we are working in our pilot with an organization called Young People Recovery, who are wonderful. And I strongly recommend, especially for those of you who, similar to me and Ashland, are like, I don't know any kids. I don't know what the kids are doing these days. See if there's a Young People for Recovery chapter in your area. They're all over the place, and their chapter leads are working with us on this project, and they're very, very smart and innovative in ways of reaching youth, especially in these strange late COVID days that we're in right now. Yeah. What else? What about issues of parents not providing consent? Is that something that either of you have come across?
Most of my parents have been kind of in the room firsthand, very concerned. So I've not had a problem with that, because they've actually been there. Whether they have their own SUD issues or whatever the issue is, I've not had consent be an issue yet. Sharon?
Yeah, I think if the parents are in the loop of what's going on, they would much rather have something that's much safer and they can actually address the problem rather than having their child continue.
What about Sublocade? Is Sublocade safe for youth after day 7 of the intro time?
I don't know that it's been studied. I'm certain someone on this on the chat can answer that. I haven't looked into it myself because I don't use it in the ED, but if anybody knows, that would be awesome.
And Marianne Gould's one of our very first and really pioneering substance use navigators with the program, is sharing that she is a parent, and she's saying that when she tries to talk to parents about drug use, they're often uninformed as well. So that is why we mentioned that critical piece of providing families and caregivers the support that they need. While we're talking about peer support and other forms of education, I want to draw awareness to our substance use navigator training. The next training is coming up on November 18th, which is a week from tomorrow, and that will be looking at harm reduction trends. And I imagine everyone who's bothered to join this training today reads a lot of news about what's going on in the opioid epidemic space, and a lot of these, safe syringe access and fentanyl strips and all these new things that sound like really great ideas and are not being widely implemented. I know I'm very curious in learning more about them. So if you are too, that's going to be a good training for you. And the registration link was just shared in the chat. So this is our contact info. This is Reb's and Sharon's. I'll put my own email in the chat. And before we take a few more questions that are coming through, I want to make sure everybody knows, I know we've gotten a lot of nice comments from you that you like a particular slide or you want the recording, and that's great. We encourage you to take these slides and this recording and share it with colleagues. We are also available. Reb, Sharam, and a whole host of other folks who are on our clinical team are available to come to your hospital and do this education. So the only thing better than sharing a recording is sharing time with an expert. So you can always reach out to me or if you have a connection to CA Bridge that you've developed at one of our coaches, you can reach out to us and we can make that happen for you. So keep that in mind, especially as COVID restrictions are getting a little bit lighter. We can now go back to doing things in person at hospitals also, which is nice. So just an option for those of you who are wanting to share this information. What else? What else is coming up for folks? Reb, Sharam, what's coming up for you as you look at the feedback we're getting in the chat?
I really appreciate people sharing and letting us know what's going on. And we're going to continue to use, a lot of these questions to make sure that, we have the information online and available for folks.
Yeah, and Wendy Martinez, who's another one of our founding substance use navigators, who is a coach for our team as well. I think pretty much, Wendy, you've summed up the entire focus of this training, which is any medication is safer than opioids youth are getting on the street. So many of these barriers that I'm saying, can I dose this? Can I dose that? What about this type of medicine? I think that Wendy's takeaway is exactly right. Any of this is better than what they're buying off of Instagram stories, right? Oh, good question, Tana. Is parental consent required to hand out naloxone?
I checked in with one of our Bridge teammates on that specifically, not legal advice, but one of our Bridge teammates, and was told there is not a parental consent requirement for naloxone, but that is not legal advice. That's peer-to-peer. That's what I was told. And
we have a naloxone toolkit, which hopefully someone brilliant from my team can drop in the chat. And that naloxone distribution toolkit is a really, really good thing to have in your hand if you are looking to increase recovery access in your community. It gives you advice on how to on how to access naloxone for your hospital. Good question.
Doctor kind of nails it again. I would absolutely like to see somebody coming after me for providing naloxone. Absolutely. Love it. Peer-to-peer. Appreciate it.
Can buprenorphine be used for meth addiction or overdose? Oh, sigh. I will direct you to, maybe we can get this put in the chat too. I'm not sure what my folks have at their fingertips. We did a session just like this on stimulants in July. And Reb, you can give us the TLDR of what we know about stimulants right now.
So hard.
You have 5 minutes, go.
Well, I mean, we're trying, right? Contingency management has shown some of the best changes. We've been trying medications, obviously peer support. Stimulant use disorder is a challenge. If anybody has some wonderful information that we are missing, I will take it. But yeah, we're working on it. We're trying to come up with different programs and how we can support patients in their recovery. Stimulant use disorder is tough, and we're looking at it as a Bridge team and multiple teams actually to try to figure it out.
Thank you. And our event specialist was able to find that YouTube link. She just put it in the chat. That was an hour-long training we did about stimulant use disorder. And again, the primary takeaway is we really don't have the evidence for any treatment that we can fully endorse right now. There's nothing that's FDA approved, but as a program, California Bridge is looking into that, researching and evaluating that from many, many angles. So always happy to provide support to answer those questions. Great. Yeah, Dina, there's a lot of different emerging treatments happening. Just nothing has been FDA approved yet. So we're always happy to talk about the pros and cons of different treatments that we've tried. Great. Well, thanks very much, everyone. I think we can go ahead and wrap up our training. And if folks do have additional questions, we're happy to stay on for a few minutes. And thank you for all your kind words in the chat. We do this all so that we can share it with you. So thank you for showing up. And again, we would love to hear from every single one of your hospitals with what you're working on and what we can do to further support you. Thank you so much. Thanks, everyone.
Thank you.
Yeah.
Thank you.
Anyone has any other questions? Again, we can stay on for a few moments here. Thank you, Wendy. Bye. Yes, the training on the 18th. Yes. Brenda Aria had put that in the chat. I'll see if I can scroll up. You know what, Brenda, if you go to cabridge.org/training, it should be there. So there you go. There's that link. It should be the first link on the page. Bye, Tana. Yeah, there's a couple other good guides out there about minor consent. Thank you. Yes, we'll be sending out the slides and the recording probably on Friday. Tomorrow's a day off for us. I hope it's a day off for some of you on the training as well. So today is Friday, and then Friday is Monday and Friday at once for those of us with 9 to 5 office jobs. Oh, I wish I worked 9 to 5, but it's fine. Yes, great. Thank you so much. Thanks, everyone. All right. Caroline, I think we can go ahead. Let's see what we still got a couple things coming in here. Retention in youth is it's difficult to maintain for anybody. Yeah, retention of adults. Yeah. Retention's hard, but you got to start somewhere. Oh, thank you. Yes, we're always looking to make good use of our time. It's my ongoing battle with myself. So thanks. Oh, thanks, Liz. Thanks, Liz Stanley Salazar. It's so nice to have you here. Let me know if you want to talk about any of this that we talked about from the purposes of your world. Liz is from our YOR supporters. Yeah. Great. All right, Caroline, I think we can go ahead and cut it.